I am a nephrologist, and nephrologists are very interested in calcium and phosphorus because the kidneys are so important in regulating vitamin D metabolism and calcium and phosphorus as well. But this talk really doesn't have much to do with chronic kidney disease. It has a lot more to do with healthy children and bone disease in all children and in adults as well, because bone health, and that's really what this talk is about, in childhood is really a predictor of fractures and bone disease in adulthood. And so that's what I want to focus on today. I'm going to go over the physiology of calcium and phosphorus and vitamin D metabolism first, and then just talk a little bit about the effects of these things on different tissues. And then finally talk about the current recommendations for calcium and vitamin D intake in children and adults, and talk a little about the evidence behind these recommendations, which you can judge for yourselves how strong the evidence is, and think a little bit about what we do in our own practice. So calcium and phosphorus are hugely important for physiology in general. Calcium in particular is very important for muscle contraction, including in the heart and cardiomyocytes. Phosphorus is a huge part of energy, ATP, that triphosphate is phosphorus. And what most of us generally think about, calcium and phosphorus are present in huge quantities in bone in the form of hydroxyapatite. And this is the crystal structure of hydroxyapatite. And this calcium and phosphorus in bone provides a reservoir for all the calcium and phosphorus in the body and all the physiological actions that it has. But it also provides structure to bone and provides a scaffold for which we're built on. Calcium and phosphorus metabolism can be dysregulated, however, and cause significant morbidity and even mortality. And the classic example that we bring up about this is extraskeletal calcification. And this can happen in many tissues. It can happen in the kidneys. It's called nephrocalcinosis and lead to chronic kidney disease. It can happen in areas of injury and cause dystrophic calcification. And it can also happen in blood vessels. Atherosclerosis, so aging, atherosclerotic plaques in the vascular intima can get calcified, break off, occlude vessels. And in certain disease states, like diabetes and like chronic kidney disease particularly, we get this phenomenon where even the muscle layer surrounding blood vessels can be completely calcified and even turned into bone. And these are pathologic examples of calcium and phosphorus implications on health. So calcium, as I said, it's very important for muscle contraction and low circulating calcium levels. We're all taught in medical school you can have tetany, you can have seizures. Calcium balance, circulating calcium levels are very important. And what we're measuring when we measure serum calcium levels is the amount of calcium in the extracellular fluid. Well, where does that come from? If you look at overall calcium balance, the vast majority of calcium in the body resides in bone, okay? About 500 milligrams per day is put into bone, but about 500 milligrams per day comes out. So you're really pretty much in balance in a steady state and in an adult. Okay, that's going back and forth from the extracellular fluid. That's exchanging with cells. Equal amounts come in and out. Where the action really is taking place is what you ingest in the diet, and that is, the current recommendation is about 1 gram a day. Most people have probably a little bit less than that. Only about 350 milligrams per day of that is actually absorbed. 250 milligrams is secreted back into the gut. So just about 100 milligrams per day actually enters your body from your gut, from all that's ingested. And 100 milligrams per day actually leaves in the urine. So when we talk about what we're doing to influence calcium intake, I think it's always important to remember in the back of our minds that really, in large part, things are pretty much in balance, and what comes in and gets absorbed really is pretty equaled typically by what comes out in the urine. Phosphorus balance, similarly, the majority of phosphorus is located in bone. There's a huge amount in hydroxyapatite forming our skeleton. Extracellular phosphorus is, you do get some every day from bone resorption, but some goes from the circulation into bone with calcium to form new hydroxyapatite. This is also in equilibrium with the intracellular spaces. And of the about 1,400 milligrams that the average person ingests a day, 900, so over half of it, is absorbed. And that really is balanced by the amount coming out in the urine. About 500 milligrams per day comes out in the stool. So here again, what you eat, equal amounts tend to come out in the feces as in urine. And by pushing this up, the amount you ingest, you're not probably going to increase bone balance a lot. But we'll get to the studies on this in just a minute. An important hormone to consider when we're talking about calcium and phosphorus is vitamin D. And I want to spend a little bit of time on this slide because the term vitamin D is thrown around a lot, and there are various forms of vitamin D, and it can sometimes be confusing what we're talking about. So vitamin D itself is made from cholesterol in the skin, or is ingested in the diet from things like milk, dairy products, fish, okay? So that is the actual vitamin D. A lot of times what we're talking about when we talk about vitamin D is actually what happens to vitamin D when it reaches the liver. That's where a 25-hydroxy group is added to it. And what we measure in circulation to sort of determine if someone is vitamin D deficient or sufficient is actually this quantity, this amount that's hydroxylated by the liver. And this is often called the storage form of vitamin D. This is present in nanogram per ml concentrations or nanomolar concentrations. And when we're talking about absorption of calcium and phosphorus from the gut, it's not actually this form of vitamin D that's working for us. It's actually what happens to this form after it goes to the kidney and is hydroxylated at the 1-alpha hydroxylase position, and we get 1,25-dihydroxy vitamin D. Now, this hydroxylation in the kidney is accomplished by renal 1-alpha hydroxylase, and that's a very tightly regulated process. And the amount of 125D in circulation typically is really tightly controlled. So you have massive amounts of this floating around, okay? So nanomolar concentrations. These are picomolar concentrations, okay? So very, very, very much less. Okay, and there's a reason behind that. You would expect that, way back prehistorically, that your storage forms might go up and down depending on food availability or sun availability or winter or summer seasons, but you don't really want this level fluctuating so much. So you really want very good tight regulation here. Okay, so 125-dihydroxy vitamin D, that is really what we're talking about when we're talking about upregulating the intestinal absorption of the mineral that is going to make our bone, so calcium and phosphorus both. This form of the vitamin D acts through the vitamin D receptor to increase calcium absorption through the gut in the context of a low calcium diet. Now, it's important to also note that there is some calcium absorbed through the gut just passively, independent of 125D mediated uptake, and that occurs paracellularly and in the context of a high calcium containing diet. So the effect of vitamin D on this pathway is much less, if anything at all. Phosphate also has two mechanisms of absorption. 125D does really increase phosphate absorption, particularly in the context of a low phosphate diet. High phosphate diet, there's a lot of passive paracellular transport between cells, though. Okay, so it's important that we think about, when we think about calcium and phosphorus ingestion, that we also think about what's going on with vitamin D metabolism, because that really ramps up our ability to absorb calcium and phosphorus. Parathyroid hormone, I want to touch on this because it becomes very, very important, particularly in the context of low calcium and low vitamin D intake. Parathyroid hormone is a hormone that's secreted by glands in the neck that is released when serum calcium levels are low. So there are a couple stimuli for this to be released, but the primary one is hypocalcemia. And this is a very protective response. This hormone will actually tell the kidney, look, the serum calcium levels are low, you have to ramp up 125D production in order to get the intestines to absorb more calcium. And it does that very effectively, so 125D levels go up and intestinal calcium absorption goes up. The parathyroid also, however, talks to bone and says, you've got these big stores of calcium and phosphorus there, release some of it into circulation so we don't get into trouble. So PTH will increase calcium balance, circulating calcium levels in two ways, by resorption from bone and by getting the kidney to generate more 125D. It also tells the kidney to get rid of that extra phosphate that is being that is coming into the circulation by increased intestinal and bone resorption. Okay, there's another hormone too that is stimulated more by phosphorus. We're going to talk a lot less about this one, and that's fibroblast growth factor 23. It is important in certain disease states. When we're talking about overall bone health in children, probably this is not the one we're focusing on the most. But PTH, which causes bone resorption and demineralization of bone, can come into play quite a bit. So fibroblast growth factor 23 is another one that in the context of high phosphate, the bone releases this hormone. This actually suppresses 125D synthesis by the kidney, but also causes the kidney to waste phosphate. Okay. So we talked about calcium and phosphorus and their importance for multiple tissues and their importance for bone, and they are critically important for bone strength, peak bone mass, overall bone health, and for fractures and bone deformities. However, bone is not concrete, is how I like to think of it. Bone is a very active tissue type that is very cellular and it's very organized. So we have two types of bone. We have cortical bone, which is the bones surround in the long bones primarily, and we have trabecular bone, which is primarily in the vertebrae, in the mandible, in the skull. These two types of bone are a bit different. The long bones have a lot of cortical bone that provides a lot of strength, but they also have these lattices of bone, the trabeculae between the cortices, also contributing to structure and strength. Okay, and I bring this up because how these things are put together, not just the amount of calcium and phosphorus in them, is very, very important for bone health. And you can see that in this picture. This is actually a picture of bone from someone with kidney disease, but I think it's pretty illustrative of the problem we run into when we just think about packing calcium and phosphorus into bone, and somehow that way we're going to increase bone strength. So in this picture, oh, there, I got my cursor back. This is a portion of trabecular bone, so that lattice between the cortices. Now, these should all be connected nicely, providing a nice, strong structure, and I'll show you someone with osteoporosis, a picture of someone with osteoporosis in a minute, which demonstrates what happens when that all becomes disconnected. This picture also demonstrates a number of other things, that you can get these disconnections between bone that might not be reflected in sort of total bone density overall, but you can also get other things. This area of green staining, this is mineralized bone. So this is where the calcium and phosphorus is packed in nicely. However, along the edge here, this is bone matrix, so the osteoblasts, the cells that lay down bone, are doing their job and laying down this nice matrix. This should be accumulating mineral and turning into this nice green color. In this picture, there's huge amounts of this. It's not happening appropriately. And why is this? Well, is it a lack of calcium and phosphorus? That might be, but there are other processes that regulate this as well. There are also a lot of cells in bone, and how they're regulated is also important for bone health. Okay, so why should pediatricians and why should we in general in the population care so much about bone health? Well, the big thing overall throughout the world that is a huge factor is osteoporosis. And if you look at the burden of disability of different chronic conditions worldwide, you see that osteoporosis affects a huge number of people, primarily adults worldwide, contributing to huge prevalence of fractures, which lead to significant morbidity and even mortality. Think about hip fractures in the aged, for instance. It's the second most common after only lung problems. Okay, the process we're talking about here in osteoporosis is one of low bone volume. So these trabeculae that I was talking to you about that should form these nice lattices, making a nice strong structure, they're thin, they're weak, and they're disconnected. Okay, when you evaluate this, the way that's usually done to look and see if someone has osteoporosis, particularly in adults, is called a bone mineral density scan or a DEXA scan. What this does is you put someone in the scanner and electron beams are put through them and are recorded in sort of a two-dimensional plane, and it tells you the amount of mineral in grams per centimeter squared of that whole three-dimensional person in a two-dimensional plane. Why is that important? Well, if you have a uniform population, all their mineral is in bone, they're all the same height, they've all got the same sort of structure of bone, and adults are pretty uniform that way. They've all kind of got similar structure to their bones. There might be differences in height, but you can sort of calibrate for that a bit. Then you might get a pretty good estimate of how much mineral content is in the skeleton of those people. If you have a growing child, however, whose bones are changing shape, whose heights are varying markedly, the readings that you get may be very misleading, and that is something we run into. It's a big problem in pediatrics, trying to interpret these bone mineral densities. The other problem in certain disease states where there's calcium and phosphorus residing in other tissues, and maybe large amounts, such as in diabetes, such as in chronic kidney disease, this bone mineral density scan will give you the total amount of mineral in the person in that plane where the beam is going through, and not necessarily in the skeleton. So if they have aortic calcifications, it's going to make it look like their vertebral density is much higher than it really is. Regardless, if you have an adult with normal kidney function, those are pretty good markers. That's a pretty good predictor of who's going to have fractures down the road. And the reason we care about that is that your bone mass in adulthood predicts fractures, but the bone mass you have an adult is very much related to how much you acquire in childhood and where you end up your maximal amount, the peak bone mass. That tends to be in a healthy individual at around age 30. So here you are, you're increasing bone size, increasing calcium and phosphorus all through childhood, really through puberty, and even into your 20s you're accumulating some. At age 30, there you are with your peak bone mass. And from then on, you're either plateauing or you're beginning to lose. So this is the reason, this peak bone mass and age 30, this is the reason why osteoporosis and the worldwide prevalence of osteoporosis is really a pediatric problem. Okay, I mentioned to you that DEXA is the way that bone mineral density and these fracture risks are typically estimated, and also told you that in children this is problematic, and this slide just reinforces the official position of the International Society for Clinical Densitometry. Really stress that this in children, if you're going to do a DEXA, you need to use height and age specific standards, and there are certain disease states, chronic kidney being one, that DEXA is really not recommended in because of the possibility for extraskeletal calcifications and the different compositions of bone that are not reflected by DEXA. I want to take a minute and get back a little bit to, aside from osteoporosis, which is sort of the main thing worldwide we focus on, and talk a little bit about defective skeletal mineralization in growing children. Okay, this is not osteoporosis, and if you were to do a DEXA scan on this individual, you might see low bone density, but this is this patient's bone with Rickets, which in adults is called osteomalacia. This is that trabecular bone I showed you before. As you can see, this is massive. It's all connective. There's a lot of bone volume. The problem is these light areas, this is the areas of unmineralized bone. These dark areas are nicely mineralized. The problem is this patient has enough bone mass, they're just not getting mineral in. This, worldwide, the leading cause of this phenomenon is vitamin D deficiency. So a child with this condition, the treatment absolutely is vitamin D and calcium. The pathogenesis is you have either very low intake of vitamin D or not enough sun exposure. That leads to low intestinal calcium absorption, which stimulates secondary hyperparathyroidism, which brings calcium and phosphorus out of bone. It also revs up the 125D synthesis to maintain normal calcemia. But because of the high PTH, you get low phosphorus, you get poorly mineralized bone. And on labs, for anybody who's a resident here and who might end up having to take boards, if you remember, these patients have very low 25D levels, end up with high PTH levels. Their phosphorus levels are also low, although their calcium levels are normal. This kind of rickets, this kind of bone disease, absolutely should be treated with vitamin D. Aside from calcium, probably if you replace their vitamin D, they'll rev up their intestinal calcium absorption and correct the whole problem with calcium in their bone. But this is absolutely should be treated with vitamin D, and there's excellent evidence behind that. There are other kinds of rickets, and just want to touch on this very briefly. In children, we sometimes see these rare genetic diseases associated with really low serum phosphorus levels. What vitamin D deficiency also is, right, because of the secondary the hyperparathyroidism that accompanies it. But these patients have very low 125D levels and normal PTH levels. This is due to just phosphate wasting from excessive bone secretion of this hormone FGF23. In children with normal kidney function, these diseases are very rare. They've taught us a lot about bone diseases in other conditions, but this is, if you run across these children with normal PTH levels and low 125D in combination with phosphorus, these are due to excesses in FGF23. Okay, so coming back to osteoporosis. So this worldwide epidemic that we have, what is this due to? And it tends to be much more prevalent in countries like India, countries with sort of poor nutrition in childhood. Is this due to vitamin D and mineral deficiency? Well, there was a very, very large study ongoing for over a decade in the Women's Health Initiative that evaluated calcium, vitamin D in fractures in over 36,000 postmenopausal women. And these women were randomized to receiving a gram of calcium carbonate a day in addition to 400 international units of vitamin D, so 25 hydroxyvitamin D, or to placebo. Okay? So these are the results after 7 years. There really was not a huge difference in fractures at the hip, at the vertebrae, the lower arms or wrist, or overall rates of fractures either. However, in a post hoc analysis of this data, when they went back and looked at the women who baseline weren't self-medicating with vitamin D, they did find that actually they were able to reduce hip fractures possibly a little bit in women who at baseline were not receiving vitamin D supplements. So stratified for personal vitamin D and calcium use at the start of the study, there might have been an effect of vitamin D and calcium in reducing hip fractures, but not other kinds of fractures in these women. So maybe calcium and vitamin D in adult postmenopausal women helps a little bit. This study, however, is very interesting. This study was done in Mahayana Buddhist nuns and omnivorous women. So these Buddhist nuns were vegan, and they were in the postmenopausal age group also. And it evaluated bone density in these women. It was a small sample size, 100 in each group. But the very interesting thing was, in this small sample size, they really couldn't find a huge difference in bone density in any of the sites they evaluated between women who had a calcium intake very low, 330 milligrams a day, and those with twice the intake, still low, but twice the intake. Okay? So this study concluded that in these women, there was really no significant correlation between dietary calcium and BMD. So these numbers were not the 36,000 of the Women's Health Initiative, but at these very low calcium levels, I found this quite striking that they really found nothing. However, and I think these data from this investigator, Seaman, is very striking, that probably our best chance of treating adult osteoporosis in the pediatric population, and this is a quote taken directly from his paper, Senile Osteoporosis is a Pediatric Disease. In this study, he looked at mother and daughter pairs and did bone densities on these girls and their moms. And it was very interesting. The mothers with the lower bone density tended to have daughters with lower bone density as well. And this was particularly true in the lumbar spine. Another study by Callworth et al. Looked at non-Hispanic white women over the age of 20 and went back and asked these women how much milk they had drunk in childhood and adolescence. And they found that women who always drank milk had, when they were children and adolescents, had much lower risk of fractures than women who very rarely drank milk as children and adolescents. There was actually a twofold greater risk of fractures in the low milk intake group, really suggesting that nutrition and calcium nutrition and vitamin D nutrition in childhood really might be affecting bone health later on. So this epidemic of osteoporosis we see in developing countries, and India is a classic example, which is actually escalating and is contributing to, it's estimated that 30% of adults in India suffer from osteoporosis. Might be an effect of poor nutrition in childhood. However, it's really pretty clear, and I think we all know this from clinical practice, that other factors really affect bone health as well. There are people that have sort of non-standard dietary preferences, and the sort of the classic one that can result in rickets is the macrobiotic diet. And I can't say that I know I'm all that schooled in what this diet entails, but it does end up in a diet that is very low in vitamin D. And in a study from the Netherlands in 1990 reported that 28% of young children whose parents placed them on this form of diets had clinical rickets. And they attributed this really to the very low serum 25D levels that these children had, 18 nanograms per ml, as compared to the 32 nanograms per ml in the control group that was on an omnivorous diet. So there is an epidemic of obesity in our country and in the developed world, really. And so then the question arises, is being overweight, is that putting people at increased risk for fractures and future osteoporosis? This study by Mary Leonard in 2004 suggested that actually bone density in obese children is not lower than it is in non-obese controls. Whether this is the bone that they're making is really good quality bone, very strong, that this remains to be seen, I think, in the future. But this data seems to suggest that obesity itself is not resulting in low bone density. Exercise is pretty clear, has a very positive effect on bone density and bone strength. And a couple of studies have looked at athletes, and actually they've looked at tennis players and the bone densities between their dominant arm and their non-dominant arm, and found a real increase in bone mass in the dominant arm, the one they're always using to exercise. And one study looked at Z-scores in different places in the head, the arms, and the legs. And I do not know why the bone density is lower in the heads of male soccer players than in their or male weightlifters. Male weightlifters maybe, but male soccer players, I don't know why they're lower than the general population. But they certainly had higher bone density in the legs, and the weightlifters in the arms and the legs. And the female gymnasts also in the arms and the legs than their non-active controls. Exercise and nutrition, though, they combine. And one thing that general pediatricians I know see a lot of is this female triad of some, and particularly girls, but there are boys also, who are highly competitive athletes and have some disordered eating as well and end up with amenorrhea. And this is really a bad triad for bone health. This study looked at bone density T-scores in both the back, the lumbar spine, and the total hip of patients with hypothalamic amenorrhea versus those with anorexia nervosa-induced amenorrhea, and bone dense as compared to controls. And having low, hypothalamic amenorrhea results in low bone density due to the decrease in the hormones, but having the nutritional component as well really decreased bone density in these young women, essentially. And I just want to remind you of that curve when you see when people are accruing bone mass to achieve that nice peak bone mass from which everything else is all downhill. This is the age range, these teenage patients, when they really should be accruing a lot of bone mass to achieve their peak bone density. Genetics is something we don't understand very well, but clearly has a major factor on bone density. And the most striking evidence we see of this, this is a very, very nice paper in the Journal of Clinical Endocrinology and Metabolism. It looked at differences in bone density at a number of sites in both boys and girls between children of different ethnicities. And really, there was not a huge striking difference between Asians, Hispanics, and whites, but in every category, particularly in the girls, you see that bone density at every site is much higher in African American girls than particularly in white girls. And why this is not at all well known. These girls, the African Americans, tend to have lower 25-hydroxy vitamin D levels. So it's a little bit. It's not explained why they accrue bone so much better than other ethnicities, but genetics plays a huge role here. Chronic illness also, and we all know this from clinical practice, can really contribute to poor bone health, from inflammation, from poor diet, from lack of exercise. All of these things together can put children at risk. And when you have children with chronic illness, their bone health is something I think we all need to be thinking about. It's maybe not when they're immediately hospitalized, probably not the first thing we're focusing on, but when we're taking care of them chronically, we need to be aware that these children, many of them are a setup for fractures later in life, if not even in childhood. I want to touch base on the systemic complications of abnormal mineral ion homeostasis, because it has bearing on how aggressively we try to start pouring vitamin D and calcium into people. So this is a pretty striking data set, I think, from 2004, from the general population. And it demonstrates that bone density, bone calcification is really related to calcification other places. And this study looked at the amount of calcium deposited in the aortas of women in the general population as compared to their bone density. And the really interesting thing is that women with the best bone density, the strongest bones, tended to have the least amount of calcium deposited in their vessels. Those with the worst osteoporosis tended to have the worst cardiovascular disease. They're like this. We don't completely understand the pathogenesis of this phenomenon, but bone and cardiovascular disease go together. This is particularly true in chronic kidney disease, not to bash you guys over the head with chronic kidney disease too much, but this is something we all think about. And certainly what we do for calcium and phosphorus metabolism in children and adults with chronic kidney disease has bearing on their cardiovascular health. It's becoming more and more apparent. I haven't talked too much about how much phosphorus we've ingested, because it's usually the amount of calcium and vitamin D that we ingest that people focus on for control of osteoporosis. But phosphorus is also a major part of bone. But phosphorus deficiency is not a problem. Really not a problem in the United States. And in fact, this is something that's becoming more and more of a problem, because phosphorus is very linked to protein. So any protein that we eat, particularly meat protein, has a lot of phosphorus with it. Any food additives have a lot of phosphorus added to it. And this study from 2014 demonstrated in almost 10,000 adults aged 20 to 80 that, and this is from the NHANES database, that ingestion of phosphorus over about 1,400 milligrams a day, and that's not huge amounts really, was associated with progressive increases in the risk of mortality. These are in relatively healthy adults, no cancer, diabetes, kidney, or cardiovascular disease. This might have something to do with the hormone I mentioned briefly, FGF23, which is stimulated, it's produced by bone and stimulated by phosphorus intake. This appears to have direct effects on the heart itself. There's more studies that need to be done to understand this. But regardless, I would be remiss if I didn't talk some about the consequences of phosphate and phosphate additives on American health. Phosphate additives are in everything that's processed, basically. All the stuff here and all of these things that you can barely pronounce contain huge amounts of phosphate, and they're preservatives, so it's good. It keeps food safe longer. Who eats these foods? It doesn't tend to be people of higher socioeconomic status. It tends to disproportionately affect people of lower socioeconomic status. So this becomes really pretty important when we start talking about cardiovascular disease, health disparities. And the bioavailability of all this phosphate matters. And it's becoming really pretty clear that vegetable proteins have much less bioavailable phosphate attached to them than does meat. So probably we'd all be better off on vegetarian diets, but it's hard to change people's eating patterns. So that's phosphorus. That's my little rant about too much phosphorus in the diet. Getting back to calcium and vitamin D. So if this, I showed you the data from the Women's Health Initiative, that these women were taking a gram extra of calcium a day, okay? And it was maybe decreasing hip fractures a little bit, but the data was not that strong. Where is this calcium in supplements going? If it's not going into bone and making the bone so much stronger, where is it going? Well, it can come out in the feces, or the kidneys could be excreting more of it, I guess. But the other risk is it going into soft tissues, including blood vessels and including the kidneys, making more kidney stones. Fortunately, I have to say that the data from the Women's Health Initiative suggests that there is actually no increase in coronary death or stroke with this extra calcium and vitamin D intake. So we're probably not causing a lot of harm if we recommend extra calcium and vitamin D intake. There was a 17% increase in kidney stones, however, so that should be considered particularly in people probably with a previous history or a family history of kidney stones. So I just want to do an overall review of vitamin D and calcium and what it's been known to positively impact. So rickets, so children with low vitamin D levels who have bony deformities, poor skeletal mineralization, clearly vitamin D is essential to treat that. So the data is very, very good that that's essential. Vitamin D is probably very helpful in women with preeclampsia too. The studies on that look really pretty good. And I put this one, I really, looking at these data, especially in places in the world where nutrition might not be so good in pregnant women, treating pregnant women and their young infants with vitamin D really seems to increase birth weight in infants and young children. So these might be areas where vitamin D and calcium are really beneficial. When you look at the systematic review that was published by the USDHHS in 2014, bone mineral density, not so much affected by vitamin D and calcium. Risks of fractures, maybe a little decrease in hip fractures. Muscle strength, data is really not there. The data is not there on reducing infections, cancer, autoimmune disease, asthma, all-cause mortality, blood pressure, cardiovascular disease. And all of these things were investigated because when I showed you that slide on vitamin D and the different kinds of vitamin D, the kidney is not the only thing with 1-alpha hydroxylase. So immune cells, macrophages, monocytes have their own internal 1-alpha hydroxylase. And it's been thought, and there were a number of correlative studies suggesting that if you have higher 25D status, you might be able to affect immune function much better. I'm not sure that the trials have really borne that out, however, but there's still ongoing studies and more needs to be done there. So what are our current dietary recommendations? These are from the Institute of Medicine in 2011, and I have to tell you that not everybody was happy with these recommendations. The kidney disease community really thought that the vitamin D intake and levels that the Institute of Medicine was recommending were too low. So that is just a caveat, but really, is recommended starting at age 1 between 700 milligrams per day, going up to 12 to 1300 milligrams per day in the teenage years, going back down to 1 gram per day in adults. And it used to be that 400 IU per day was what was recommended for vitamin D intake, and that was increased by the Institute of Medicine in 2011, modestly to 600 IU per day. The AAP does recommend that all infants, children, and adolescents have a minimum daily intake of 400 IU of vitamin D beginning soon after birth. In formula-fed infants, this isn't such a problem because the formula is supplemented with vitamin D. But exclusively and partially breastfed babies need to receive some vitamin D supplement. And that should be continued until they're weaned to at least a liter or a quart of vitamin D fortified formula or milk a day. Children with chronic illnesses, there's not a lot of evidence on the best way to modify diet for children with chronic illnesses, those on corticosteroids, those with really low levels of exercise, of what their vitamin D levels should be, how much calcium intake they should get. And coming back to, the data from the nuns with low calcium intakes and the macrobiotic diet, there's not a lot of reliable data on the lowest calcium intake that we need to achieve to prevent rickets, or on the relationship between race, vitamin D status, physical activity, and diet in the causation of rickets. So the best we can do is just kind of look at high-risk groups, those with really poor dietary intake, the third world particularly, children at risk with dark skin pigmentation, with diets very poor in vitamin D, and really assess them for vitamin D deficiency. What's the optimal level for vitamin D? This is a topic of that's really contentious. I just want to, for anybody taking care of these patients, just be aware that there are a difference in units. And I think in nanograms per ml, but a lot of people think in nanomolar per liter, and there's a conversion factor of 2.5. So a number of 30 nanograms per ml would be 75 nanomolar. Okay, so the Institute of Medicine recommends that levels be at least 20 nanogram per ml in circulation. The kidney disease community really recommends those levels be higher. Is there a risk of too much vitamin D? And I would argue that yes, there is. And I think this is a little bit underappreciated. There was a study, this is from the basic science literature, Journal of Clinical Investigation in 2012, showing that vitamin D actually can inhibit skeletal mineralization. It can cause bone to demineralize. And if you knock the vitamin D receptor out of osteoclasts, you prevent this completely. So if you're toxic on vitamin D, you will not be driving more calcium and phosphorus into bone, you'll be taking it out. Okay? And this study from the JBMR from 2 years ago now demonstrated that while low levels, they found that low levels of vitamin D, less than 15 nanograms per ml, so that is pretty low, that's vitamin D deficient by everyone's measures, was associated with increased fractures. Levels above 30 nanograms per ml were also associated with higher fractures. And that these were in older men, and that the men with sort of the lowest rates of fractures had levels between there. So maybe the Institute of Medicine, their value of 20 is a pretty good recommendation. So I just want to sum up by saying that there's a difference between rickets, poor mineralization of bone, and osteoporosis, which is low bone volume. Both contribute to fractures, and I think we need to distinguish in our minds what we're dealing with. In children, we can be dealing with either one, okay? Vitamin D deficiency is the leading cause of childhood rickets worldwide, and supplementation in pregnant women, vitamin D supplementation in pregnant women and children in high-risk areas, probably very beneficial for growth, bone health altogether. And also calcium intake and vitamin D intake in childhood and adolescence likely affects peak bone mass. And I think, we as pediatricians, if we really want to address a health problem that's going to be affecting people later in life, we can really do something by improving diets in our school-aged and adolescent patients. I'd just like to say Happy New Year.